Welcome to This Week in Obstetrics and Gynecology. This week we're covering 10 notable papers spanning postpartum cardiovascular risk and obstetric management, safety and stratification in gynecologic oncology, and strategies for improving preventative care and patient partnerships. Let's dive in. We begin with postpartum cardiovascular health and critical choices in delivery management. A prospective cohort study published in Ultrasound in Obstetrics and Gynecology examined the incidence and predictors of hypertension at 5 months postpartum in 678 women with a history of gestational diabetes mellitus. The researchers excluded patients with pre-existing chronic hypertension and invited participants back for a comprehensive clinical assessment. Remarkably, 26.4%, more than 1 in 4 women, developed hypertension at a median of 5.1 months postpartum. When looking at risk factors, postpartum hypertension was significantly associated with older maternal age, Black or mixed ethnicity, higher early pregnancy weight, elevated early pregnancy blood pressure, and the development of preeclampsia or gestational hypertension during the index pregnancy. Notably, women who developed postpartum hypertension had a significantly higher median body mass index of 30.1 compared to 27 in the normotensive group. They also had a much higher prevalence of an elevated waist-to-height ratio, which exceeded 0.5 in nearly 88% of the hypertensive group, compared to 69% of the normotensive group, and dyslipidemia was also significantly more common. However, the study found that predicting postpartum hypertension using only early pregnancy risk factors yielded modest detection rates, highlighting a critical clinical implication. We cannot rely solely on early risk profiles to identify these patients. Instead, we must implement universal postpartum blood pressure assessments for all patients who had gestational diabetes. Furthermore, these patients frequently exhibited other cardiorenal metabolic abnormalities at 5 months, including dysglycemia in over half of the cohort, abdominal adiposity in nearly 3/4, and dyslipidemia in over 1/4. This underscores the postpartum period as a vital, highly actionable window for early cardiovascular intervention. Moving from postpartum health to delivery itself, a massive Swedish population-based cohort study published in PLOS Medicine investigated the long-term neurodevelopmental outcomes of children delivered via vacuum-assisted delivery. Analyzing over 630,000 term singleton births to premiparous women with a median follow-up of 13 to 14 years, the researchers compared vacuum-assisted delivery at various stations to emergency cesarean delivery and spontaneous vaginal delivery. They found that mid to low vacuum-assisted delivery was associated with significantly higher odds of immediate neonatal complications compared to emergency cesarean delivery. Specifically, it was associated with an adjusted odds ratio of 7.2 for traumatic intracranial hemorrhage, 3.65 for non-traumatic intracranial hemorrhage, 3.35 for subgaleal hematoma, and 1.85 for neonatal seizures. However, the long-term neurodevelopmental follow-up yielded highly reassuring results. There was no associated increase in the risk of attention deficit hyperactivity disorder, autism spectrum disorder, cerebral palsy, or epilepsy. In fact, mid to low vacuum delivery was associated with a 20% reduction in the risk of intellectual disability compared to emergency cesarean delivery. Meanwhile, outlet vacuum-assisted delivery showed no signals of adverse neonatal or long-term neurodevelopmental outcomes, performing similarly to spontaneous vaginal delivery. While these findings should not dictate emergency intrapartum decision-making, as registered data cannot fully capture the acute clinical circumstances leading to these interventions, they provide powerful, reassuring data we can use to counsel patients who are anxious about the long-term cognitive and neurological impacts of an operative vaginal birth. These complex delivery decisions are further highlighted in an expert clinical opinion, which proposes a major paradigm shift in how we manage placenta accreta spectrum. The authors argue that traditional classification systems focusing solely on the depth of placental invasion fail to predict surgical complexity or guide uterine preserving strategies. Instead, they introduce a topography-based framework for prenatal ultrasound and surgical planning. This approach emphasizes that placenta accreta spectrum is a disorder of uterine scar remodeling. By using prenatal ultrasound to map the precise lesion topography, lower uterine segment anatomy, cervical involvement, and pelvic vascular remodeling, multidisciplinary teams can better anticipate pelvic vascular changes and tailor surgical strategies. This shift from routine peripartum hysterectomy to individualized topography-guided surgical staging allows for safer, more precise uterine-preserving surgery in carefully selected patients. Integrating these imaging and surgical staging concepts into a single decision-making framework can help clinicians translate emerging evidence into everyday practice. Next, we turn to critical advancements in gynecologic oncology, where survivorship and surgical precision are taking center stage. A landmark retrospective cohort study published in the American Journal of Obstetrics and Gynecology addresses the long-standing controversy surrounding the safety of hormone therapy in young cervical cancer survivors. Concurrent chemoradiotherapy for locally advanced cervical cancer frequently induces premature menopause in patients under 45, leading to severe metabolic, skeletal, and cardiovascular morbidity. Despite guidelines, hormone therapy remains underutilized due to persistent concerns regarding oncologic safety. To evaluate the association of hormone therapy with long-term outcomes, researchers analyzed over 4,600 propensity score-matched patients from a large multinational database, using a landmark analysis at exactly 1 year to eliminate immortal time bias. Initiating estrogen-based hormone therapy within the first year after chemoradiotherapy was associated with a 41% reduction in the risk of developing type 2 diabetes, occurring in 5.3% of the hormone therapy group compared to 9.8% of the untreated group. It was also associated with a 29% lower risk of cerebrovascular events, occurring in 5.1% versus 8.9%, and a 31% lower risk of compression fractures, which occurred in 3.1% compared to 7.4% of untreated patients over an 11-year median follow-up. Most importantly, there was no increased risk of thromboembolism, breast cancer, or colorectal cancer, and hormone therapy was associated with a 19% improvement in overall survival. These findings strongly support the safety and systemic benefits of early hormone therapy, indicating we should routinely prescribe it to young patients following chemoradiation. In the surgical management of pre-invasive disease, a multicenter cohort study at Final Pathology, occult endometrial cancer was diagnosed in 47% of the patients, with 16% of those cases classified as intermediate to high risk. Sentinel lymph node mapping proved safe and feasible, slightly increasing operative times, but finding sentinel lymph node metastases in 4.7% of those with occult cancer. Crucially, sentinel lymph node status modified subsequent adjuvant treatment decisions in 50% of the patients who received adjuvant therapy. Positive sentinel nodes led to chemotherapy escalation in 5 patients, while negative sentinel nodes supported the safe omission of chemotherapy in 6 patients who would have otherwise been treated based on uterine pathology alone. This suggests that sentinel lymph node biopsy provides highly actionable prognostic information and should be considered during hysterectomy for atypical endometrial hyperplasia to optimize surgical staging and avoid both undertreatment and overtreatment. When performing major gynecologic oncology surgeries, minimizing mortality when complications do occur is a key quality metric. An analysis of over 100,000 patients from the American College of Surgeons' National Surgical Quality Improvement Program investigated the incidence and risk factors for failure to rescue, defined as death within 30 days of experiencing a postoperative complication. The overall complication rate was 5.5%, and the failure to rescue rate among those who experienced a complication was 4.8%. Interestingly, the specific surgical procedure performed was not independently associated with failure to rescue. Instead, the strongest predictors on multivariable analysis were the occurrence of any severe complication, which increased the odds of failure to rescue nearly 5-fold, followed by preoperative hypoalbuminemia, which nearly tripled the risk, and perioperative blood transfusion, which increased the risk by over 60%. Increasing patient age was also a significant factor, with a 3% increase in risk per year. Patients who experienced failure to rescue had an earlier onset of their first complication and underwent earlier reoperations. This indicates that patient-level factors and physiological reserve, rather than the complexity of the surgery itself, drive mortality after a complication. Clinicians should focus on targeted preoperative optimization, particularly correcting hypoalbuminemia, and implement intensified postoperative surveillance for older patients and those requiring transfusions. We conclude with essential updates in health equity, preventative care, and clinical partnerships. A study in gynecologic oncology examined the barriers to cervical cancer screening and the acceptability of mailed at-home human papillomavirus self-collection kits among underscreened women in a United States safety net health system. Comparing foreign-born Hispanic, United States-born Hispanic, and United States-born non-Hispanic women, the study found that foreign-born Hispanic women had a significantly higher prevalence of barriers to traditional Papa Nicolau screening, including discomfort with male providers, embarrassment, pain, transportation difficulties, and fear of cancer. While overall satisfaction with the mailed self-collection kits was high across all groups, foreign-born Hispanic women expressed greater anxiety regarding proper sample collection, safety, and confidentiality. This highlights the need for tailored, culturally sensitive educational materials to reassure patients of the accuracy and safety of self-collection. In parallel, a clinical committee statement in Obstetrics and Gynecology emphasizes the role of obstetrician gynecologists in normalizing discussions around human immunodeficiency virus prevention, screening, and pre-exposure prophylaxis, or PrEP. OBGYN should routinely obtain comprehensive sexual histories, assess local epidemiological data, and engage in shared decision-making regarding the route and form of PrEP to reduce acquisition disparities. Finally, another committee statement in Obstetrics and Gynecology champions the integration of doulas into clinical care teams. Evidence demonstrates that partnering with doulas improves patient satisfaction, enhances communication, ensures patient-centered continuity of care, and lowers overall healthcare costs. Obstetricians are encouraged to lead efforts within their hospital systems to foster collaborative, symbiotic relationships with doulas to optimize perinatal outcomes. If you only have time for one paper this week, make it the multi-institutional cohort study on hormone therapy after chemoradiation for locally advanced cervical cancer. This study provides robust, long-term evidence that initiating hormone therapy in young patients undergoing chemoradiation significantly reduces metabolic, skeletal, and cardiovascular morbidity while improving overall survival, directly challenging the historical safety concerns that have led to widespread undertreatment. Here are the key takeaways from this week in Obstetrics and Gynecology. First, implement universal blood pressure screening around 5 months postpartum for patients with a history of gestational diabetes, as 1 in 4 will develop postpartum hypertension. Second, confidently counsel patients that while mid to low vacuum-assisted delivery carries transient neonatal risks, it does not increase the long-term risk of neurodevelopmental disorders compared to emergency cesarean delivery. Third, routinely initiate hormone therapy in patients under 45 years old who undergo chemoradiation for cervical cancer, as it reduces long-term systemic morbidity without compromising oncologic safety. Fourth, consider sentinel lymph node biopsy during hysterectomy for atypical endometrial hyperplasia, given the high rate of occult cancer and the utility of nodal staging in guiding adjuvant therapy. Finally, optimize patient outcomes by addressing preoperative hypoalbuminemia in gynecologic oncology patients to prevent failure to rescue, and by actively integrating doulas into the care team to enhance perinatal experiences. That's your roundup for this week in Obstetrics and Gynecology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.